So for this clinical trial, we enrolled about 45 patients with myelofibrosis that had either already been on ruxolitinib to treat their myelofibrosis symptoms or splenomegaly, or they initiated ruxolitinib right as they were getting ready for transplantation. And the goal of this study was to test the safety and efficacy of giving ruxolitinib during transplantation and afterwards. And the reason why we chose this was because ruxolitinib, as well as the other JAK inhibitors, are approved to be utilized only before transplant. However, when patients stop their JAK inhibitors before they go to transplant, and while the transplant is taking effect, which can take several months, patients can experience a rapid return of symptoms and splenomegaly. And so many transplant physicians will restart their JAK inhibitor in the post-transplant period to try to ameliorate these symptoms. However, JAK inhibitors like ruxolitinib have not been studied in that setting. Now, ruxolitinib is approved for steroid-refractory graft-versus-host disease, which is a common complication after transplantation, but it's not usually utilized before patients develop graft-versus-host disease. And so therefore, we wanted to study if giving ruxolitinib during the transplant period and after would help several things: prevent those symptoms from coming back, prevent splenomegaly from occurring again, and also by mitigating graft-versus-host disease and hopefully improving the outcomes of our patients. And so this study was conducted across the United States, and the primary objective of the study was to evaluate the 1-year graft-versus-host disease-free, relapse-free survival. Secondary endpoints included overall survival, progression-free survival, engraftment, incidence of acute and chronic graft-versus-host disease, as well as seeing how long patients were able to remain on ruxolitinib as a measure of feasibility. All patients received reduced intensity conditioning with fludarabine and melphalan, and patients usually receive peripheral blood stem cell grafts, most of them from match-related or unrelated donors. And they got standard prophylaxis for graft-versus-host disease with tacrolimus and methotrexate. So we enrolled 44 patients, 43 of them ended up undergoing transplantation, and this occurred between September of 2018 and May of 2023. The median age of our patients was 66. 37% of them were female, and most patients had either intermediate 2 or high-risk disease as measured by the DIPS scoring system. Generally, patients did pretty well. We didn't see increased rates of poor engraftment or graft failure compared to historical controls. With a median follow-up among survivors of about 13 months, we saw that the 1-year GRIFFIS, or graft-versus-host disease-free, relapse-free survival, was 74%, with a 1-year overall survival of 86% and a 1-year progression-free survival of 79%. And the non-relapse mortality and disease relapse rate were 10% for both. So we were pretty excited about that. And in addition, we saw that the cumulative incidence of grade 3 and 4 acute graft-versus-host disease at 6 months was only 2.4%. And only 1 patient had grade 4 acute graft-versus-host disease. Also importantly, at 1 year, the rates of moderate or severe chronic graft-versus-host disease was 11%, which again was also pretty low compared to historical controls. So, we're excited about these preliminary results. We're going to continue to follow all the patients until they complete at least 1 year of treatment, and then we'll follow them. They'll be on ruxolitinib for 1 year, and then we'll follow them afterwards to see how these outcomes continue to progress over time. We're also interested in seeing how their mutations change over time, and if we can utilize those to get a better understanding of their outcomes. And so one of the issues that we have with myelofibrosis is that it takes patients a long time to recover their blood counts after transplant, and sometimes it can be very difficult to distinguish those patients that are in remission but have low blood counts versus patients that perhaps are going to relapse, because those bone marrow biopsies, if you do them a few months post-transplant, will still have fibrosis. And so we're trying to see if we can utilize data from these patients to get a better sense of different predictors of outcomes. And so those studies are still being conducted at this time.